Fowl cholera, cholera or Pasteurellosis. Definition: fowl cholera is an infectious disease of poultry, waterfowl, and many other birds, usually appearing in poultry as an acute septicemic disease with high morbidity and mortality. A chronic localized form, most common form in chickens, occur in poultry and may follow the acute form or may occur independently. Occurrence: fowl cholera is a disease of many species of birds, including chickens, turkey, geese, ducks, quail, canaries, and many wild and zoo birds. Geese are highly susceptible. Fowl cholera is more likely to occur in birds that are stressed by such things as poor sanitation, parasitism, malnutrition. There is no relationship between cholera in human caused by Vibrio cholera and fowl cholera. Historically, fowl cholera has been recognized as a disease of poultry for more than 200 years. About 100 years ago, Pasteur isolated the organism and used it in one of the first vaccines in the United States. Dr. Salmon studied the disease as early as 1880. Fowl cholera was one of 4 major livestock diseases that stimulated formation of the Veterinary Division of United States Department of Agriculture. Although fowl cholera has been recognized and studied for almost 200 years, it still remains an important disease of poultry. Etiology: the etiological agent is Pasteurella maltosida, a gram-negative bipolar staining growth that grows readily on blood agar but not on McConkey agar. Virulence: among the isolates is highly variable. Encapsulated strains are usually highly virulent. Uncapsulated isolates are typically of no virulence. Capsulated are virulent. Uncapsulated are of low virulence. The organism varies greatly in its antigenic makeup, a characteristic responsible for difficulties in producing effective bacterians and vaccines. The gel diffusion perceptin test has been used to describe 16 Pasteurella maltosida serotypes, all of which have been isolated from avian host. Serotype 1, 3, 3x4 are most commonly isolated from poultry outbreaks. Pasteurella maltosida is easily destroyed by many disinfectants and by sunlight, heat, and drying. Epidemiology: poultry flocks. Poultry flocks that have recovered from an outbreak is to susceptible flocks. Poultry flocks that have recovered from an outbreak of fowl cholera will remain carrier of Pasteurella maltosida and spread the disease to susceptible flocks. Several mammalian species are carriers of Pasteurella maltosida and may introduce the organism to poultry flocks. Swine and cat raccoons have been shown to be carrier of Pasteurella maltosida, and these isolated have been shown to be pathogenic in poultry. Clinical signs: with acute cholera, sudden unexpected death occur in the flock. Mortality often increased rapidly. Laying chickens may be found dead on the sick birds show anorexia, depression, cyanosis, rales, nasal or oral discharge of mucus, and white watery diarrhea or guinea mucoid diarrhea. The course of illness is short and often followed by death. Chronic fowl cholera. Chronic fowl cholera is most common in chicken. Often there is swelling of joint, wattle, foot, pad, and tendon sheath. Oxidate of caseous may accumulate in a conjunctival sac or infraorbital sinus. There may be torticollis in a few pores. Abscesses of infraorbital sinus and mild ear infection resulting in torticollis often occur in turkeys with chronic cholera. In turkey breeder, there is a drop in egg production and increased mortality following handling of hen during insemination. Affected toms produce thin, watery, poor quality semen. Lesions may be absent if the disease is very acute. Usually there are petechial and coimutic hemorrhage at a few sites, for example on the heart, under serous membrane, in mucous membrane, or on the gizzard in abdominal fat. In layer and breeder hen, free yolk in the peritoneal cavity, acute oophorytis with regression follicles. In acute disease of cholera, as With other septicemias, there often is hepatomegaly. If the bird lives a few days, there may be a few or many small necrotic foci in the liver. Consolidation of lung is a common finding in affected turkey. With time, these lesions become sequestrated as necrotic areas in the lung, and these lung lesions often are extensive. In chronic disease, there may be localized inflammatory lesions. These often involve a joint, tendon, sheath, wattle, conjunctival sac, infraorbital sinus, the nasal turbinate and middle ear, the cranial bones at the base of the skull. Cases of the in a localized lesion should arouse suspicion of cholera. Diagnosis: at necropsy, gram-stained depression smear of liver, spleen, heart, blood from septicemic cases often reveal bipolar stained gram-negative rods, suggestive of Pasteurella maltosida. Use of a blood stain or methylene blue readily demonstrate the bipolar morphology of the organism. Although the history science lesions may strongly suggest fowl cholera, Pasteurella maltosida should be isolated and identified for confirmation. Isolates should be tested for antibiotic susceptibility because of widespread resistance and should be serotyped, especially if routine treatment and vaccination procedure appear ineffective or if a vaccination for future prevention is desired. Cholera must be differentiated carefully from erysipelas and acute colibacillosis in turkeys and other birds that are susceptible to both diseases. Several serological tests have been developed. Currently, an enzyme-linked immunosorbent assay, ELISA, is commercially available and widely used. Serology is used primarily to evaluate efficacy of vaccination rather than for diagnosis of disease outbreak. Live vaccines are given via wing whip inoculation to chicken and via drinking water or wing whip inoculation to turkeys. In the United States, live vaccines are based on Kalamazoo University strain of Pasteurella maltosida, this naturally occurring low virulent organism. Milder mutants of the origin CU strain have been produced. BM1, M9 strains, they frequently are given in turkey at 2 to 6 weeks and beginning at 6 to 7 weeks of age in the drinking water. Turkey breeders are vaccinated via the wing whip layer and the breeders are inoculated by wing whip stick at 10 to 11 weeks of age and revaccinated in 6 to 8 weeks. Fowlpox vaccine may be given concurrently in the opposite week. The live vaccine have been shown to be safe, but vaccine reaction problem can occur in the field. Following an outbreak, depopulation should be considered because many surviving birds became infected.